what we'll do is, it's 8 past, so I think we'll start now. So thanks everybody for joining us again today. Good morning and good afternoon, everyone. Thank you for joining us for the second of our webinars and discussions on building Africa's frontline readiness in the health tech sector. I am Nankunda Katangaza, co-founder of the African Law and Tech Network, who are your hosts today. So our conversation today builds on our first webinar, which was held on the 23rd of June, which explored the legal, policy and regulatory issues in Africa's health tech sector. Our panel of experts explored some of the bigger picture issues around the challenges of integrating tech solutions to national public health strategies, which included looking at the lack of flexibility in the 5-year planning frameworks that are sort of ubiquitous across the continent. We also talked about the need for enabling regulatory frameworks, and also the lack of understanding and knowledge of tech on the regulatory side and what it can do, and also looking at the broader legislative environment within which health tech and other general tech innovation takes place. And we specifically looked at issues regarding data protection and privacy, which are very pertinent to healthcare sector. So our discussion today will take a bit of a closer look at how tech innovation and building an inclusive health tech sector can be facilitated by other sectors, professions, investors and institutions. This is obviously very critical for African countries in the post-COVID era, but also to address long-standing and perennial public health needs, which have a sort of a light being shone on them at the moment. Last night I watched a documentary that was looking at South Africa specifically and how the COVID pandemic, and this is a country that often is referred to as relatively progressive in terms of its health care provision on the continent, but how the COVID pandemic has really shone a light on some of the big gaps in provision there. So we will be building on what we discussed at our last session as well. So, and some of our speakers from the previous sessions and attendees are here today too. So that makes for a really good chat. So before we kick off, just a few housekeeping points. The panel will discuss various issues for just over an hour, and then we will open up to questions. Please direct any questions and comments to panelists via the Q&A tab or on the chat function. You can use the chat function, which will be moderated. The session will also be recorded and streamed on the Alt Networks channel on YouTube. And we will also share some highlights and the video as well on our websites in due course. If you want to tweet about this discussion, please use hashtag alt, capital A, capital L, capital T, health tech, or hashtag Africa Health Tech. We will also put in the chat our speakers' Twitter handles so that you can tag them in anything that you want to say that's related to what they've talked about. We will also be running a couple of polls during the course of the discussion, so look out for those. And I hope they won't disrupt too much, but we'll try and put them in the right junctures. So without further ado, I'm going to introduce our panelists, who I'm really delighted to have with us today. My first panelist is Robert Karanja. Robert is co-founder of Vilgrow Kenya, where he is spearheading the replication of the Vilgrow incubation model of social entrepreneurship and impact investments in the healthcare and life sciences industry. Robert has over 10 years experience in global health R&D as a biomedical scientist at the Kenya Medical Research Institute, where he discovered his passion for impacting people's lives through science and innovation. Robert also holds a PhD in medical parasitology and entomology. Next, we have Dr. Lett Ulema, who is a woman who wears several hats. She's currently the CEO of an Ethiopian health tech startup working in the healthcare sector, and she's created a cloud-based, connected, patient-centered electronic health record system. Dr. Ulema is also Honorary Associate Professor and Director of the Center for Digital Health and AI at Wollo University in Ethiopia. And she's passionate about developing African tech talent and solutions that are relevant and appropriate to the environment in which they are deployed. Maxine McIntosh is our next speaker, and she's a co-founder of healthtech UK, which is a global volunteer-led grassroots community that supports and promotes underrepresented groups in health innovation. The community has over 14,000 members across over 15 hubs and is expanding globally all the time. Her day job is as a research associate working between the Alan Turing Institute, the Health Foundation, and the University of Oxford, so another busy person. Maxine's work applies machine learning to large National Health Service data sets. She also holds a PhD in dementia in electronic health records. Dr. Roy Maega is a medical doctor and lecturer in the Department of Epidemiology and Biostatistics at the School of Public Health, Makerere University in Uganda. He teaches epidemiology and research methodology at both graduate and undergrad level. Roy is also Deputy Chief of Party at the Resilient Africa Network, which is housed at the School of Public Health at Makerere. And he has over 20 years experience in public health related work and extensive experience also in resilience programming. Kenneth Muhanji is a partner at KTA Advocates in Uganda and at the Amani IP Network, which is an East African network of intellectual property specialist firms. Kenneth is a specialist in IP, technology, media, telecoms, and dispute resolution. He has conducted specialized trainings in areas of ICT, such as blockchain technology, digital banking, and data protection, among others. Kenneth is also an advisor to the government of Uganda on the integration of ICT into the adjudication processes, and also advises the Ministry of ICT on innovation and ICT policy development. Kenneth also represents Uganda at the 4IR portfolio communities of the Center for Fourth Industrial Revolution of the World Economic Forum. Andrew Kwao, who is our health tech here today, last but not least, is co-founder and COO of Redbird Health in Ghana. Andrew is an entrepreneur, public health and international development professional, several years experience in the sub-Saharan Africa healthcare sector. Prior to Redbird, Andrew worked for 2 US government-funded projects focusing on improving health systems and the promotion of the use of malaria rapid diagnostic services in health facilities, including pharmacies. Andrew is highly motivated with a passion for developing innovative solutions for improving healthcare delivery throughout sub-Saharan Africa, and passionate about improving the speed and quality of healthcare delivery. Thank you so much all. It's a pleasure to welcome an extremely talented panel. I'm feeling slightly overwhelmed here, but I'm sure that makes for a great conversation. So I'm going to start off with asking Dr. Ulema to just give us a little lay of the land from your perspective, Letta, especially given that you've worn several hats looking at healthcare systems. What do you see as the gaps and challenges for African governments and systems in terms of facilitating this innovation in health tech? You just need to unmute yourself.
Yeah. Can you hear me? Thank you. Thank you, Nakunda. I'm sharing my screen. I'm honored to be here. Let me. Can you see anything? I don't know why. Just a moment. Sorry, can you see my screen? No?
Not yet.
Okay. What about now? Let me. share screen. Unfortunately, I don't seem to be able to share my screen.
The tech has let us down.
Yeah, I'm honored to be here and to be a panelist in this very important discussion. When Nakunda asked me to present, I was asking myself where to start. I am a public health person. Maybe I'm not IT. I studied tropical medicine and public health. I've been working in public health in Africa for, I don't know, almost 30 years. But around 15 years ago, I started getting interested in health, digital health, and what it can do for public health in Africa. I will still do one more attempt to share my screen. If it works, it works. No. So when I started, the challenge for me was you can't see anything.
It says it started sharing, but we can't see it just yet.
What about now? Yes? It's sharing from my side. I don't know why it's not coming, but okay. So when I started the work 15 other projects, funded projects that are US government funded to help the Ethiopian government to strengthen monitoring and evaluation in Ethiopia, especially in the age of HIV/AIDS, to make sure that there is a strong monitoring and evaluation system. So we started working on one side on capacity building, on the other side trying to create the paper forms that are necessary to capture HIV/AIDS information because of drug interaction, because of resistance and all those issues. There has to be a system. So unfortunately, my screen won't show you what I want to show you. I wanted to show you an Ethiopian chair, which is for me, that says it all. It's a three-leg chair, maybe it's in many African countries, that people sit in the rural area. It has 3 legs and you can sit. So for me, in Africa, but in other places also, when we talk about digital health, there are 3 things that are important. Human resource, the software or the digital solution, the infrastructure, and the things you sit on, for me, is the law, the data interaction. So when I started this work, I understood that we cannot just you have to do all. In order to have a successful system in Africa, a system, number one, has to have the human resource, the people that are needed to not only to use the system, but also to make the systems, the digital systems, whether it's mobile health or e-health or whatever we want to call it. And then infrastructure. If there is no infrastructure for me goes both connectivity and also hardware. If there isn't, then our effort to look at a country level will be very hampered. And then the third thing is the appropriate software, not a software that is parachuted from somewhere, but a software that understands the way that people live in our villages, people live in bigger cities, in small cities, in districts, in province. So for me, actually, I wrote a paper a few days ago that for me, for any person not to lose their medical record is a human right. For me, a village person that goes to the village clinic has to be assured that their medical record is secure. Just because they are not educated or poor or whatever, doesn't matter. So that's how I started. So when I started, I felt, wow, the problem is too huge because we have to address all these dimensions. So I try to help and work with the government to tackle it almost simultaneously, but maybe work more on the human resource first. I think we need to spend, this is 15 years ago now in Africa, in Ethiopia also, we have produced thousands of IT professionals and thousands of young people who understands health and IT. It's not only important just to have somebody who's IT, a software specialist. No, we need people to understand the sector also. So sometimes people like me and my other colleagues who are in medicine are very important because we can explain the sector. It's not a software. Our problem for me is not a software or technology problem in Africa. Our problem is to use all the knowledge that the world has. So much things out there, blockchain, we talked AI, we said all of it. How can we make it appropriate for Africa so that we can solve the problem at the village level and also as mega cities like Addis. So that's how I started. So we work with Ministry of Education, Ministry of Health to have a brand new curriculum. I think before us, the only country who did this for almost 20 years was Kenya. Kenya had some kind of health information cadres. After us, South Africa, Nigeria, and others have started. But so we started that. We spent time and effort to make sure that the young people are educated. They understand us, the health sector, so that if they go and create something tomorrow, it is appropriate to us, to our mothers, to our children, to our fathers, to our farmers, to our nomads. So we have to make sure that. And then the second thing that we started working was networking, infrastructure. Like in many African countries, connectivity was getting very fast. But in reality, the last mile connectivity is not there, if we are all honest. Yes, we have better connectivity in our mega cities, but in the villages, what kind of connectivity we have? So if for me, when we talk about digital health, it has to be equitable and accessible digital health. It can't be only for few and not for the rest. We cannot leave them behind. So that is a big challenge. And we started thinking many things. The governments in every country in Africa now are building broadband, 4G, maybe some will do 5G, but is that reaching Mr. X in a village? That is very important. Why? Because Mr. X in a village or Madam X in the village needs about maternal health, about her data, all this included. So we are also now thinking of something called white space. Tanzania is going in an interesting way in that technology. Zambia, I know, have experimented it in telemedicine. So we have to think of the extra mile where the big tech companies or the big telecom companies are not going to that village. They have to have a reason to go there. If they don't have any reason, if they don't get money, why would they go there? So does that mean that we forget them? No. So we have to think of different out-of-the-box solution. So I'm experimenting with those kind of thinking also. And then the biggest thing that currently that is very important is we need factories in Africa to produce our tablets, our cell phones, our little computers. How are we supposed to do all this if we don't have? And if we don't produce, that means we have to import. And the importation has to be very cheap so that it can reach the population, all population in Africa. So that has to be, I know Uganda is thinking about it, another Kenya is thinking about, and currently somehow producing, assembling, I should say, some kind of tablets and computers. I think that needs to be increased. Because if we don't have all these pillars, then it is useless. Then the biggest thing is data security for me. There are so many information of Africa. When I started, just to go back, I studied immunology, vaccine research. So for me, I thought African problem. We don't have vaccine, we need to get vaccine. Then I started working in Zimbabwe and Namibia. By that time when I was working, vaccines that were produced 10 years ago were not in Africa. So I said, forget it. I'm not saying vaccine is not important. I said, okay, first we have to have systems. If things that are produced in America or Europe, whatever, if it takes 10 years to vaccinate our kids, there must be some other problem. So for me, it is very important that systems, when we think of in Africa systems, and data security is very important. I'm glad that we have a lawyer today with us. We tried to work in Ethiopia when we started. There was no health law. Forget digital health. There was no health law. But now in 15 years, I have seen so many things in Africa, strategies many countries have, but still I don't think it is enough. I don't think African data is secure, personally. It's going all over. For me, a few years ago, somebody told me now data is the new oil. I do believe it is. So I think in all our technology, like I said from the beginning, it's not about technology. It is about to use all this knowledge in the world, how to make sure our population benefits. So I'll expand later on when you ask me a question. I'm grateful, and I'll try to fix and show you at least that little chair by the end of this presentation. Thank you very much.
Thanks, Waletta. You know we can actually see your little chair.
Oh, you can?
Yes, it showed up.
Oh, excellent, excellent. Thank you very much.
So we've had the little chair in the background while you were speaking.
Oh, thank you very much. Great. I couldn't see it. For me, it's blank.
Oh, right. No, we can see it.
Okay. So
Yes.
this is all.
Yes, it is on. Yes, absolutely.
Thank you.
So we can bring it back later. Thank you. Thanks for that. Good sort of background setting and all the different issues actually that you highlighted there, which we will discuss in more detail. I'm sure our participants will also be interested in more. So I wanted to go on to Roy, Dr. Maega now, and particularly your work with the Resilient Africa Network. So which is a good example of implementation of technology and health tech in hopefully an overall public health strategy, which I'm assuming and hoping that your work fits in with the Ugandan government strategy, for example, or any other countries. Can you tell us a little bit about that project and your work on that?
Yes, thank you very much. The Resilient Africa Network is a higher education-based innovation lab. So our base is students. We work with students and we try to get ideas and innovations from them. That is the simplest statement I can make because the process is not as linear as it appears. When we started this lab way back in 2012, we did a quick assessment of the innovation capacity for universities, and we found quite a number of barriers, and that resonates very well with what we are discussing now. First of all, the setup of academic programs does not rhyme with innovation activities. Innovations being viewed as extracurricular activities and not mainstreamed into the usual training, but also the lack of these incubation centers where the students can get the skills. The previous presenter talked about the internet and bandwidth, so they need these spaces, but also the maker spaces for, let's say, fabrication. These are quite expensive things that a single student cannot gain access to, but also access to high-risk financing. When you fund 100 solutions, the ones that may make it to the market will be just 5 or 10 if you are lucky. So who is going to give that money, a lot of which will just go through the basket? Somebody has to pay that bill. And then we also observed very quickly that some groups are left out of the innovation space, including digital innovations. And it is because of some gender alignments in the courses that some people take. The humanities having more of the female students versus the sciences, and yet humanities are central to innovation. Yet what we found in the universities is that technologies, health technologies, you're talking about medical school, you're talking about engineering, you're talking about computer science, and yet the problems they solve are for the community. So we had to quickly realign this. And maybe one other issue is multidisciplinarity. The students don't talk to each other. For instance, one quick coincidence when computing students visited the labor ward and they saw the midwives listening to the mothers using a very old gadget. It's called a fetoscope that has been used for 200 years. And the computer students said, what are they listening to? Is it audio? If it is audio, we can amplify it. But this was just coincidental. How do you create those opportunities that students can work in a cross-disciplinary way? So this comes to the way we operate as a lab. First of all, what we do is we try to filter the health issues, the challenges, because the students need to know which are the challenges that need to be solved. So we consult the communities, we consult also the communities of practice and frame the challenges in form of innovation challenges, and then we put them out to the students. Then we select those with good ideas. They will quickly come up with ideas. Then we select them. After that, they need a lot of hand-holding, incubation support, training. Some of them will have heard of design and these digital tools for the first time. They have the idea, they don't know about the tools. Linking them to people who can support them and improve their skills, including in health technologies, and then giving them some seed grants. So we then give them a seed grant when we know they are ready. And then we sort of help them to handhold them on issues, for instance, of intellectual property. Some students don't want to open up their idea because they know that a certain their research or supervisor is going to steal the idea. They don't know nothing about IP, about starting a company, and all these. These are some of the things that a lab like this helps to solve. And then I wanted to give just some two case studies of how this might play out. During the the massive Ebola outbreak in the mid-2010s, there was this issue of, in West Africa, very difficult working environments for healthcare workers, and there was this innovation call that we put out to improve the care conditions. And that is how some students came up with the improved EpiTent. It's called the EpiTent. It's a humane structure with very good airflow. It promotes infection prevention, but it cools the environment also by 10 degrees centigrade in a very hot, humid climate using just natural means. So when the students are guided to a problem, they are able to identify technologies that can solve the problem. And here comes COVID. The units are now being used. The Ministry of Health has procured 10 of these units and distributed them as part of the emergency spaces for catering for COVID patients. That is one of the slides that I wanted to show. So you guide the students, give them a problem to solve, and then take them through, give them the logistics, and then you get a product. But even when the product comes out, you have to support them to scale it. Now, I'll conclude with the overall direction that we are thinking. I think the health technologies that we are developing should be steered to address the key issues in public health, which is the high burden of preventable diseases, but also the rising burden of non-communicable diseases. We have chronic care patients that are increasing that need to be followed up. And then we also have the emerging pandemic threats. So in terms of the areas where we think digital technologies will work a lot is the issue of turning our medical records into electronic records. We still have largely paper-based systems. So our students should be guided on how to hack this and present a solution that works in our context, given the resource constraints. Issues of virtual health care, clinics that are so far away to reach a health consultant, how can they be connected so that they can get this advice closer? So the issue of telemedicine, point of care diagnostics, mobile health applications, especially for chronic care patients, smart dispensing of drugs for chronic care patients, so that we've seen in COVID, people have been cut off from health facilities, people with HIV and others, but they don't need to constantly go there. How can they get smart dispensing points where you can, issues of 3D printing? There are so many medical equipment, small equipments like airways that can just need to be 3D printed and not imported. And then data. The previous presenter talked about data. The data in Africa is increasing, and our students should be guided on how to hack it so that we can improve surveillance systems for challenges like COVID. And then new ways of disseminating health information. In this COVID, we've seen that misinformation can move much faster than how we want to deliver the information. And these are some of the areas where our students can contribute ideas on how to harness the different platforms to pass on information. So I'll stop there for now, but also to note that through this mechanism, we were able also to develop a low-cost ventilator, which is now undergoing clinical trials. The mechanics of it have been well set up. The electronics are well set up. It's 95% locally made materials. It is using valves that are derived from old cars. So the same valves from cars are being hacked by the students and used. They've written the software. There are only one or two small components that they need to import. So when the students are appropriately guided, I think they can solve some major health challenges. I'll stop here for now.
Roy, thank you so much. That's so exciting. It just sounds so exciting. I love it. I mean, you know, yeah, brilliant. Anyway, I'm not going to say very much. I just want to ask a couple of questions on the Resilient Africa Network. Is it operating in more than one country? What you're doing currently in your innovation lab and incubation lab, and if so, which countries?
Yes.
And also, are the students all from the public health department, or is it a combination?
Yes, I'll quickly answer those. So we have labs distributed across Africa. We have 4 labs, one in South Africa, one in West Africa, East Africa, and then Jimma University in Ethiopia. And the key thing is why you need those multi-centers to come together is to agree on a common way of unpacking the approach. So what we do here is what is done in Pretoria, what is done in Jimma, and what is done at the University for Development Studies in Ghana. So we agree that this is how we are going to engage the students, and then we go out. So we are spread across Africa, and we involve 20 universities, but clustered around the four labs. In the second question was to
do with, are the students all from public health, or are they from different disciplines?
The students are cross-disciplinary. So what we do is that when we are framing the problems, we go to the community and we ask them some simple questions. What are the issues you are grappling with, and how do you think they can be solved? Then we frame them into challenges and we put them out open. But we encourage, as a must, the students must work in cross-disciplinary teams. And we examine, if you are dealing with something, even if it's tech, do you have an anthropologist or a social scientist on the team? So we try to see the cross-disciplinarity that is required to solve that problem in a way that it can go down to the communities.
Great, thank you very much. I'm going to turn to Maxine now, because I think from what we've heard both from Roy and Willetta, we've got a really broad view of some of the issues, and also the efforts that are being made to actually have an inclusive kind of approach to these things. Maxine, can you tell us a little bit about what some of the challenges are to developing inclusive health tech sectors, but also from what you've heard just now, where there might be already some signs of excellent practice?
Yeah, no, brilliant. Thank you. And thank you so much for inviting me. This is not the usual panel that I sit on. Usually it's kind of NHS IT conferences about interoperability standards. So this is a much more exciting panel to be part of. So I guess I've really been fascinated by the culture innovation in Africa for such a long time. My mother did all her research in the Gambia. My partner has worked in Somaliland for 15 years. I just finished a multi-month fellowship in Kenya and Uganda. And I definitely leave my African trips much more inspired than when I interact with my European counterparts. And it's because of this much more hacking away in a regulation light environment. You realize when you come from such a regulation heavy environment that has risks and problems, but also there are huge constraints in terms of how free thinking you can be. So I always walk away from my interactions feeling much more inspired. So dovetailing on from what Roy and Willessa said, I really, what Willessa said around it's all about tapping into that knowledge. For me, this is a huge thing about what One Health Tech does. So as Nankunda said, One Health Tech is a grassroots community that operates as a distributed network that looks to support better diversity and inclusion in health tech. We started in the UK, but we've now got hubs in Melbourne and Stockholm, and we'll be launching a hub in Nigeria very soon, and increasingly other places. And really, we care about making an inclusive health tech sector because, as a number of the speakers have said already, if you don't have a diverse group of people, a representative group of people who are building innovations, you will never build the right innovations to the communities you serve. And that is important at the local level. An individual doctor or, as Roy said, an individual anthropologist or sociologist to feel welcome into a local ecosystem of innovation is so important, because if they don't feel that on a one-on-one level, then how on earth are they going to be able to contribute to the best innovations? But then this also then is super important at the global level. A huge amount of capital flows out of places like Silicon Valley, and funnily enough, a bunch of men in hoodies in San Francisco doesn't translate very well internationally in terms of the innovations. So it's really kind of important that we think of this at both the local and the global level. So we definitely view diversity and inclusion in the sector as directly affecting health outcomes. So there's a whole bunch of examples of when you don't create a diverse and inclusive environment, health suffers. So for example, clinical trials, 90% of clinical trial participants are white men in their 20s. And we definitely now know the huge variation in physiological responses to different types of medication based on your age, your gender, your ethnicity, your cultural heritage, the way in which your health system is structured. All that will affect the way in which different people and different types of people respond to different types of medications. We see this with representative data sets. Nankunda before the panel sent around a really important article about the lack of African DNA data sets in global genetics research. And you see that across most data sets. So there are these huge holes in terms of how people are represented. And often it is in areas where under-resource in the latest high-tech and biotech, you just see that as a massive black hole in the data sets. But it does mean that when lots of these innovations that come from different parts of the world want to scale, they just don't generalize very well. So a really relevant one that's happening at the moment is these COVID models that are looking at the way in which different types of groups are responding to different treatments, or the way in which outcomes are varying. They simply don't translate to different populations. Lots of the early models that came from China that were applied in the UK simply didn't translate, and different countries are at different stages of their COVID pandemic. And we have to think really, really carefully about some of these generalizabilities of these machine learning models. And one that certainly in the UK people like to think about and raise a lot is that when the iPhone was brought out, in their health kit, it says you can track all the things that matter to you, and they didn't have a period tracker. And so there was a huge uproar from the female community saying it's a bit rich having a health tracker that says you can track all your physiology, and a thing that happens to half of the world once a month isn't in there. So you can really see that when you don't have diverse and inclusive voices at the table, the point at which solutions are designed, you really miss out on catering to huge populations. But we struggle, I guess, to think about how we communicate inclusivity, because inclusivity is actually very, very different in terms of where you are in the world and what group is underrepresented. As Roy mentioned, there's a huge gender disparity in the digital health sector. So in the UK, 77% of our healthcare service are female, and 11% of the tech community are female. And so then when you look at the digital health sector, it's kind of sitting about 16%. But it could just as easily be by discipline. Again, what Roy said, you really need doctors at the table, you need anthropologists at the table, you need technicians at the table. And if none of them see eye to eye, that's a huge problem. So we really think about intersectionality a lot. And so intersectionality is where if you have an underrepresented characteristic, that could be your gender, it could be your age, it could be your sexuality, it could be your socioeconomic status, that if you have more than one of those disadvantages, they compound one another. So we think really, really carefully about when we are bringing a community together, it's not just the fact that you're a woman, it could be the fact that you are female and of a certain age and of a certain background. And so you are even more at a disadvantage. So that's quite a difficult thing to kind of scale, in the sense of we want lots of people to feel like they can create an inclusive environment and they know what that means. But at the same time, inclusivity means something different to every single group of people. So the way that we've kind of looked at it from a One Health Tech perspective, which might not be the right way, and we've certainly learned a lot on our journey, is to kind of work in templates and work in frameworks, and to think a lot about supporting hubs to acknowledge their own privilege. So for example, we operate as a federated community. We work completely in the open. All our documentation is open, and anyone can both kind of poke it and prod it and improve it, but also use it as a way by which they can build their own inclusive by design health technology community. So everything is very, very framework and template based, so that anyone in the world can set up a hub themselves and start to bring diverse groups of people together. But also we focus a huge amount on understanding your privilege. And that literally just means if you are at a societal advantage. So if you are white, or if you are male, or if you are, if you did study digital health at university, is that how you can use your inherent advantage to support those around you. And so we focus a lot about how we can lift up one another, and the frameworks and the rules and the environments allow that to happen the best. And so the types of examples that our different hubs around the UK and increasingly around the world have put on is initiatives to support female founders, initiatives to support innovations that come from more deprived areas in the UK in order to get specific types of contracts with our health service, initiatives to support more female investors in order to therefore support more female founders. We run a huge numbers of programs around role models and different types of tech careers, again, to kind of demystify what is a kind of increasingly burgeoning and new area coming together. So that's how One Health Tech thinks about it. It's an inherently really complex thing, because you're not optimizing for one type of diversity or one type of inclusivity. But time and time again, especially around COVID, we're really seeing that when that doesn't happen, it does cost people's lives, and innovations can sometimes kill people, but can most of the time underserve certain groups of people. And unfortunately, time and time again, it's the same group of people that are disadvantaged.
Thanks. Thank you very much, Maxine. It sounds to me like certainly from what Willetta and Roy are already working on, these issues are already being considered as being paramount, and I think that just makes a big difference. I think Willetta, later on you can tell us a bit more about your incubation and your work with startups or with incubating tech students, but I think your focus is on IT students rather than a mixed group, so this is quite an interesting combination. We're just running our first little poll, so you can see it coming up. Just feel free to answer the questions on there very quickly, and we'll still continue the conversation. So I think I'm going to turn now to actually looking at a little bit lower down to the startup and the SME environment in health tech. And I want to start with Andrew, who is today's health tech that we're talking to in this conversation from Redbird Health Tech in Ghana. Andrew, can you give us an overview of Redbird, what you do, what your services are, and then maybe some of the challenges or discoveries, positive discoveries that you found in rolling out your service?
Thank you, Letta, and thanks, everyone. I'm excited to be here and honored. I'm going to share a screen to show you just a couple of pictures and a couple of slides for that. Do you have my screen? Great. All right. Okay. So yeah. So Redbird, we are a health startup. We try to make healthcare more decentralized and more convenient, using existing channels and just making them better. Our focus now has been on the community pharmacies, and I'm going to talk about this picture. This is a picture that I think if you grew up in Africa, if you're still in Africa, you are more very familiar with. This is an OPD of a hospital. You can see a lot of people. In here, you're going to have people who are really, really sick and want to see their doctors. And in here, you're also going to have people who are probably just coming in to check in with their clinicians to see how they are doing on a chronic disease. And I think Roy did make mention of the fact that Africa is seeing not only an increase in the existing acute disease, but you're seeing a lot of chronic diseases. And a significant portion of that are haven't even been diagnosed because part of the preventive measures and early screenings are not well rolled out. So we at Redbird, we see this as a big problem, right? Because one, you have health systems that have been developed with the acute conditions in mind. You have very low doctor to population ratio. So, and now we are having sort of moving towards the epidemiology transition where you're seeing a lot more chronic diseases. Unlike the acute diseases that we know, right? I mean, once someone gets, if you get malaria, for example, you walk into the hospital, you see your doctor, you get treatment, hopefully you're fine and you're out of the healthcare system. For every chronic disease, that patient that you diagnose, that is a patient for life. And these people need constant monitoring. Like that's the only way they have better outcomes and better survival rates. And the way our systems are set up in this way is that it means that on, let's say, a monthly basis, you're having all these people coming into the hospital, spending about half a day for something that's probably going to take them 5 minutes just with the doctor. So we saw this as a big problem. And the question was, how can we make this better? Because, I mean, one way would be trying to build more hospitals. But if you look at the economic conditions in Africa, it's impossible for governments to keep up. Even private sector cannot step in. So myself and my co-founders, the CEO Patrick and our IT guy Ed, Patrick had this vision of, he used to make rapid diagnostics back in the US and realized that, okay, the technology, when you speak of the technology for these health monitoring things, right? The technology is already there. Like they've gone way past like rapid sugar monitoring, rapid blood pressure monitoring, rapid cholesterol monitoring. The technology is already there to deliver for you like a rapid test in 5 minutes. The problem is there's no channel, like the people who are using it, the channel that is meant to be used in, especially in developing countries, there's no channel that has been developed. So we look at this and we said, okay, what can we take from the existing continent and make better? Most of the African countries, we are used to these chemical shops, pharmacies that are community-based. So you see them almost like supermarkets all around everyone. And we've come to know them as sort of like our first point of call for acute conditions. You walk in and then you get some painkiller and you walk out. And these pharmacies have significant resources, right? You have a professional who's a pharmacist, well-trained in medication, disease conditions, and all that. And they've more or less turned into places where they've just been serving medications. So we went like this. Let's take the existing rapid technologies that have already been developed, right? Bring them into a pharmacy, a place that people already trust. We already trust our pharmacies to be able to give us better healthcare. Bring them and put those two together in a way that helps people to, for example, make a half-day hospital visit, just 5 minutes in their neighborhood pharmacy. And this, in the long run, we see saving a lot of time. Not only are we taking people who don't really need to be in the clinics away, we are giving more time to the doctors to be able to see more the patients who really need them. And what we have done is we've taken the rapid diagnostic test and we've put them together with a tech platform. And you speak of trying to connect the data part, right? So a question comes up for, let's say, someone who is diabetic, right? Aged, probably not technologically savvy. They see their doctor, they get a prescription, they come back in 3 months. That's a question. How are you feeling today? How are you doing? Even if it's someone hypertensive. Within that 3 months that they are home, the doctor actually has absolutely no way of knowing how they were doing in between. All they've got to make a decision on is how the patient is feeling on the day of the revisit, which could be 3 months. So we saw this as, once we put these in the pharmacies, then these patients can go into the pharmacies in between their hospital visits. So this is not supposed to cut them off from going to see their doctor, but a way where we are able to perform their test. Pharmacies are trained, they record their test results into a system, that tracks over time. So if you look on my screen, you see on the left, you see it looks semblance of a tablet, which is what the pharmacy has. So the pharmacy has this and is able to do this for the patient, and it's all stored in a cloud network. The patient doesn't need to have a phone. Even if you have the what we in country call young phones, like the non-smartphones, the patient get the results, an SMS of the results on their phone. They probably might be able to read or might not be able to read. But this sort of breaks the tech barrier, right? Where, for example, you're having these smart tools and then you're having people who would not be able to use the smart tools. We've empowered the pharmacies to do this, have this feedback in the pharmacy and be able to provide the necessary guidance. So if you have, say, a diabetic who is suffering or who is on medication, and in between the time that they have to go see their clinician, the pharmacy starts seeing a trend that is going up. It's a quick time to say, okay, you know what? You really have to go see your doctor before the next 3 months. If everything is okay, patient is assured, patient within 5 minutes, patient has like a very good quality of life. They don't have to be spending a lot of time. And then we are looking to build this over time where on my right, for people who are tech savvy or who have smartphones, they have these results instantly on their phones. They can share this on their next visits. We also have the ability to connect directly to patients and to doctors, where for everything that has been done in the community, you could have a dedicated doctor that information could be shared with you. We are piloting that version with a team here. Where, so if you send in your patients, you now do not necessarily need the consultation in person, because you would have historical trends of how the patient is doing, and you'll be able to provide even just repeat prescriptions. And these people are in the pharmacies, they can take the medications in the pharmacy, have them refilled. And especially in these times where you don't want people coming to the hospital, especially people with comorbid conditions in the COVID times. The thing that we see and the way we've tried to build this out is we want to improve the culture of people getting used to the technology, right? So with our patient app that I showed on the previous screen on the right, we having that app already in the hands of people made it for us easier to adapt to the current pandemic, right? Because we had people, and the app allows people to self-report their sugar levels, their blood pressure. Now it became just a quick tool for people to now, instead of only having to check in their usual disease conditions, are able to check in with their chronic, with their COVID feelings, like how are you feeling, checking in through the symptoms, and then we're able to connect that to even workplaces for employers to start sort of preempting and be able to triage people into high risk, low risk. If you have someone who's been exposed to someone who's been coughing and they themselves start developing a fever, it helps you now to start looking at the data and see how you're doing with this. So it's kind of what we do at Redbird, the challenges that we've seen with the technology, the solutions that we are providing, such that we'll be able to provide a solution even for people that cannot be able to use the smart solutions, that you have the caregivers able to connect on their behalf and work through. This is my team, Patrick, myself, and Ed. And then we have a local team of fairly Africans, say Ghanaians, building this. We built this from 2 pharmacies in 2018. We are in 230 pharmacies, a network in Accra, Kumasi, in Ghana. We're looking to possibly expand to other countries, but the current circumstances have made us focus very much on Ghana. But this is what we have at the moment, and I think be happy to field questions as we move along with the conversation.
Great. Thank you very much, Andrew. That was fascinating. I'm sure there'll be lots of questions for you on Redbird and what you do and other issues that may arise. I want to turn to Kenneth now from the IP lawyer perspective, and obviously, as I said at the beginning, there are different sectors and professions whose role is critical in facilitating innovation, and particularly with startups and SMEs who are working in this sector. So Kenneth, could you talk to us a little bit about some of the IP issues relating to startups in the sector, and any of the work that you've been doing in this area, please.
Yeah, sure. Hi, everyone. Thank you for the introduction, Nkunda. So I'll just dig right in. As I was listening to Oleta, she mentioned that there is a traditional stool from Ethiopia, and I think she showed the photo and all of us saw it. And that actually reminded me of something. So I think it was in 2018 or thereabouts, that Germany patented or tried to patent the process for making teff, which is, as we all know, a very, very, very important delicacy in Ethiopia and, well, in much of East Africa as well. And it took the intervention of the Ethiopian government and lawyers who fought until Germany relented. And of course, the decision was against them. And I think in June of 2019, that's when they finally removed the patent from their patent registry. So that, starting with that, I wanted to start with that just to show really how the law is important when it comes to trying to enforce intellectual property, when it comes to enforce or promote innovation or promote all these things that we're actually talking about. Now, in relation to intellectual property, in Uganda in particular, we have a very robust intellectual property system, like in most East African countries. And really, most of the tech startups, or most of the startups in the health sector, the problems they face usually cut across, in the sense that most of them will start innovation, and a few of them will seek legal advice to be able to know that, okay, for example, one of the biggest issues is if you're going to apply for a patent, the law worldwide, it doesn't matter what legal regime that you'll be looking at, will give you just a small window that you'll have that you'll have to be able to showcase your innovation before you can be able to register it. Now, the problem with that is that with social media, especially now during COVID, if I was to use that as an example, so many innovators have come up with health tech apps, with apps that are meant to assist governments, that are meant to assist communities. But when it comes to intellectual property, and this is where the disconnect is, for most of them, they don't realize that by showcasing their innovations, their products online, or pitching them, as they're looking for money, because these are startups, as we mentioned, then there is a possibility that if they delay to register for a patent, then they may be kicked out on grounds of novelty. So that is a very, very big issue. We've had a number of innovators actually that have failed to get patent protection for their innovations, which would ordinarily have gotten patent protection, but because they have delayed. So in Uganda, the period is 9 months, I think. I could be wrong. It's 9 or 12 months. But if you don't register within that time, if you register after, you'd have to show very, 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 very strong consideration in support of why you failed to register within that particular period of time. But for most, ignorance, of course, as we know, ignorance of the law is not a defense. So you can't tell the patent industry that, oh, I'm sorry, I didn't know about the law. So that, I think, would be the most important point when it comes to IP registration. Then, of course, when you break it down as well, in terms of brand awareness as well, for most of these startups, so although most of the health tech platforms are actually providing a service or providing a solution, but you'll find that they also have an economic aspect to their business. Now, when it comes to that, of course, but even if you aren't looking at the economic part of their business, if you look at the brand itself, so having a product is good, but the other aspects that perhaps innovators miss out on is the brand as well. So you saw from Andrew how distinctive their logo is for Redbird. Andrew, I must applaud you guys for that. But that distinctiveness is very important, because if you don't have distinctiveness in your logo, then it is impossible for you to register a trademark. And that then poses a problem later. Or if you have a name or logo that is similar to others, and then you have issues with the infringement. So those are issues or considerations that have to be thought about before an innovator actually starts working on a particular platform. But very rarely do innovators actually look at those particular considerations. Then, of course, in terms of also the registration, there's very little knowledge, or very little collected knowledge that innovators can be able to get in regards to what particular IP rights they'll be entitled to for their particular innovation. So for most IP regimes worldwide, in common legal parlance, we have, of course, copyright. That's where if you have a software-based application, and then for most, if it has an element of inventiveness, if it has that inventive step and can then be produced in a factory, and of course it's novel, as I mentioned earlier, then your innovation can be able to get a patent, or if it does not have that element of inventive step. So inventive step is that element that adds that technical effect. And so if it doesn't have the technical effect, then the law still allows you to get a utility model. And then since we're still looking at patents and utility models, there's also an aspect that is rarely looked at, which are technovations. So technovations exist in our legal jurisprudence, but rarely talked about. So these apply mostly to innovations that are created in the ambit of either an organization, company, or a university like Mayega's, in the sense that if you have students that then create very innovative products, especially if you're looking at products in the health space, then although those products, although they are funded by the university or by the company, but they still require or still need recognition, in the sense that you have very, very sad stories where someone comes up with an innovation in the context of either university or within a company setting. And then because of course the company or the employer or the commissioner is the one that owns the IP in that particular system, then the problem comes later on when that particular person also has to pay to use a platform that they have innovated themselves. So that's where technology certificates come in. And I think that but we don't talk about them a lot, and yet these are things I think that would spur innovation within organizations, because most times people will prefer to innovate outside the ambit of, let's say, a company or an organization, if they're trying to create something that they feel perhaps would be able to either supplement their income. But if you have that element, if you let them know that, look, you can still be able to create something within your work environment and we'll recognize you, that also perhaps motivates them to be able to create more innovations within that setting of either a university or a company. Then perhaps I'll also say, then of course there's the trade secrets, which are really important, but rarely, I think for trade secrets, especially when you're looking at health tech, that one may be a little difficult to enforce, since you have to have your products reviewed and scrutinized to ensure that they meet the standards that they ought to have. So perhaps the last bit will be on policy, which is, I end, but again, last but not least, policy is very, very important. And in most instances, like the first example that I gave you, if you didn't have Ethiopia focusing on policy, if you didn't have lawyers filing a suit to try and say, no, look, you can't have test, which is a national dish patented by another country, then you will have lawlessness, or you will have people taking advantage of these innovators. So policy is very important, but policy is one from a national level, in terms of ensuring that, one, the law recognizes these innovations and allows for and understands the environment or the circumstances, because we cannot or we do not operate in a vacuum. And using the example I gave you before about the period of time that they give before you cannot be able to get a patent. So if you look at the considerations, especially again, for example, during COVID, we all know that most businesses have been interrupted. So if the law can be able to foresee some of these hindrances, especially even looking beyond COVID, looking at how social media impacts most of these innovations, because once it is posted, of course, it is in the public domain, and the novelty aspect is lost. Now, other jurisdictions have looked and have tried to kind of soften their laws to make them more user-friendly, to make them more innovation-friendly. So I think that is something that we need to focus on in Uganda or in Africa generally, to make our laws more innovation-friendly, because if you do that, if you focus on policy, ultimately the result will be that innovation will be spurred, and you'll have a lot more people coming out to create things that will definitely be able to help their communities and the government generally. So policy is a very, very important aspect, not only, as I said, in regards to policy on tech, but also policy in intellectual property. And then perhaps in terms of the innovations Uganda, we have quite a number of innovators that, Nankondo, you mentioned earlier that I represent and advise the Ministry of ICT. So we have a fund which the government of Uganda set up, which is the National ICT Initiative Support Program. And there are particular innovators that are supported by the government. One of those is actually Clinic Masters, which is all who are innovators that created a hospital management system application. And this is now being used by almost all the government hospitals in Uganda. So again, so that ties into the policy in the sense that if you have the government supporting local innovators as compared to getting software or applications from other jurisdictions, before looking at whether we have the capacity in-house. That is very, very important. So of course the others are M-Scan, Goji Plus, all of them, but really Andrew will represent all the health tech applications, in the sense that these are important applications that need to be supported not only policy-wise, but also regionally and internationally. Thank you.
Thank you, Kenneth. You raised a number of issues that I would love to follow up on subsequently. The IP angle, I mean, the policy point, I was going to ask Letta to say something about it, and I will again in a minute. But I'm also mindful, you did a seminar not so long ago on Amani IP that was looking at local knowledge, and it was kind of health knowledge as well, and you know, people knowing how to check if the baby's about to be born, or if there's a particular herb that's, you know, that's locally used to treat certain illnesses, and the need to protect some of that kind of group knowledge, which is which feeds in very much into this kind of health discussion, even though it's not necessarily tech, but to the extent that the two come together, it is a much broader conversation. But I want to go now to Robert, actually, because Robert, you're sitting as an investor in health tech and also incubating and working with startups. What are you seeing in terms of the kind of innovation in this sector, and what are and also the policy environment that Kenneth talks about? Is it moving to meet some of the innovation or to facilitate it? And in terms of Vilgro specifically, what are your particular priorities, and how do you see what's happening around you fitting in with Vilgro?
Thank you, Nankunda, and it's a pleasure to join you and these wonderful panelists for this webinar. I think my vantage point at Vilgro is a really good one, because we are really an intermediary organization, and our job is really to be able to speak to academia, be able to speak to the science and the technology, to speak to private sector in terms of being able to speak finance, the language of investing, the language of de-risking ventures, and to government, because government are people you cannot ignore. They really do set the agenda, whether it is the industrialization agenda, or whether it is the science, technology, innovation agenda, the higher education agenda, so the health agenda. So in everything, we basically always need to have this triple helix approach of government setting the agenda, academia generating, producing new knowledge, and private sector being able to take that knowledge and doing innovation with it, solving problems, scaling the solution, creating wealth, creating impact. And so as Vilgro, we are seated right in the middle of all that. And I think in the health space, we are very excited. I think it is one of the areas where there's a lot that needs to be done. I think it is one of the areas where, in as far as Africa is concerned, I'd call really the low-hanging fruit in terms of how do we go about development, how do we go about creating sustainability, and lifting people out of poverty. And the reason I say so is because poverty and health are really joined at the hip. In most cases, we think of disease and we see the causative agents, the coronavirus, the malaria parasite, the HIV virus. But the other side of it is to understand that we also have the social determinants of health. And I think the COVID-19 has done a wonderful job of reminding us that, hey, these are equally important, if not more, than the causative, the biological causative agents of disease. Especially when we look at North America or Europe, where it's really those who are poor that are actually really seeing the brunt of COVID-19. And so when we talk of innovation space in Africa, the health sector is the one area where we can not only deal with the biological causative agent of health, of disease, but can also really attack the root problem of disease, which is poverty. And so when we typically do the donor funding thing of coming in and saying, oh, we have a HIV pandemic. We're gonna, get everybody on ARVs. We have the vision 90-90-90. It's great, but then ultimately, if we're not lifting people out of poverty, what we're doing is really creating more poverty, and this will become more susceptible, not just to that HIV, but to everything else that comes along. And so innovation in healthcare can really start to chip away at that and move us from that vicious cycle of health, both as a determinant, but also as a result of poverty, to when we start creating a virtuous upward cycle where we say we're going to bring health solutions that are going to solve the health issue, but also start creating value chains and creating wealth that starts to ultimately lift people out of poverty and strengthen them and strengthen our economies. So we are really advantaged in another way, in that for the health sector, we've been chronically underfunded. And here is me just trying to look at the glass half full. Being chronically underfunded is nothing to brag about or to celebrate. But on the other hand, it also means, like, what Maxine was talking about, we're not weighed down by lots of investment that make it impossible for us to adopt innovations. So for enterprises like Andrew or the startups that we're supporting, there's not much barriers in terms of the adoption of technologies. From the perspective of we'd already invested in something else, and so we cannot say that yes means we're going to say no to innovations for the next 10 years. No, we don't have that barrier. So what are our challenges then? I think our challenges are really being able to, if you were to zoom out and look at Africa, let's say zoom out to the stratosphere, to be honest. You see a continent that is 17% of the global population. We have 25% of the global disease burden, probably 80 to 90% of the global infectious disease burden, and a growing non-communicable diseases burden. So and when you ask why is that the case, it's really because of our purchasing power. The issue of poverty really really needs to be addressed urgently, and it needs to be addressed from the perspective of, if you look at us again as a continent, with that 25% of the global disease burden, we are roughly about 2 to 3% of the global market for pharmaceuticals, roughly about 2% of the global market for medical devices or diagnostics. Why? Because nobody's going to invest in the R&D to solve our health problems if we're not going to give them the premium profits that they typically get in a place like America, which just by themselves, they're about 50% of the global market. But they pay typically 3 times what the Europeans pay for healthcare for the same technologies. So the license fare does not work for Africa. We have a broken market system. And one of the critical ways to address that we need to do, the things that we need to do to address that is, first of all, start understanding how do we create demand for health technologies. And so health financing is one of the key areas that we really need to focus on. And as Vilgro, we are currently supporting about 5 companies that are just looking at health finance, everything from ring-fenced savings and loans to microinsurance products to capitation, looking at different ways of understanding how do we move the African population from the issue of out-of-pocket payments. Because believe it or not, when I get sick like today and I don't have a health insurance, I'm going to be thinking, oh boy, it's around 15th, 16th. This is the hardest time in terms of, the month. I need to delay my health-seeking behavior until roughly end month when I get a salary. Now, imagine I'm a farmer, I don't even have a salary. And I'm expecting to harvest this crop, in the next 3 months to be able to get some cash flow. What does it mean? It means ultimately by the time I'm going to the hospital, something that could have been treated simply with antibiotics, now I probably need to be admitted. Costs have shot through the roof. And the burden to the health system is even higher. So how can we really address the health system? We can't do it without looking at the issue of universal healthcare and moving us from that point where we are talking of roughly about 30 or so, 35% of Africans paying out of pocket for healthcare. Actually, no, not that 5%. That 5% of all healthcare expenditure on the continent is made by out-of-pocket expenditure. That's extremely too much. The other thing is, you look at it, you realize 11% of us Africans, we typically are, paying for catastrophic. We're encountering catastrophic spending in terms of healthcare. So that means we're either selling off our assets. We're doing, crowdfunding. In Kenya, we call them harambes. We're doing all sorts of stuff to be able to meet our costs for healthcare. And in essence, and I think this is true in Nairobi, if I was to go outside this office, and every 9 people out of 10, out of the people that are meeting in the streets, are one health emergency away from bankruptcy. Because we are really just, healthcare is expensive. So we need to understand the whole mechanisms of how do we start creating this cycle. So the next thing to look at is then understanding, if the world is not willing to do the R&D investment for Africa because they see us to be too poor, who's going to do it? It's going to be the academia. It's going to be our academia that has to do this R&D. And then the next question has to be, then if our academia can do the R&D, can they be able to also commercialize it? Can they also have a business model that works for academia? And I think this is one of the areas that we are really, really struggling, because in many, many cases, we are taking the approach of the tech innovation and trying to put it in the health sector. And it's really tough. Number one, because tech is very low in CapEx. If for every bug in the Microsoft software, as we have in the software that we work with, in the drugs, in the diagnostics, would all be, saying, sue them, we can't stand this. So the error rate, the allowance for error in the health sector is very, very low. You must prove safety before you can even prove efficacy and all the good things that you want to be able to do. So health sector is different. You can't go at it like, and one of the things that I'm facing is that we are not seeing the R&D that comes from academia being packaged in spin-off companies that private sector can actually invest in. And what we are seeing is very young graduates, their first degree level, that are actually trying to innovate, but they're lacking they lack the experience, they lack the domain expertise to now be able to take the science from problem solution fit to understand the problem market fit. And so many times then what you start seeing happening in the innovation sector is lots of young entrepreneurs, amazing energy, amazing talent, but not being able to understand which are the critical problems that are worth solving, so that they can actually then be able to build great businesses. And if you look at the entrepreneurs we have on this forum, the Andrew postgraduate Ivy League, Professor, where's Prof? From Ethiopia, a whole professor. We need that caliber of entrepreneurs in the health sector. People who are not coming out of degree, their first degree, but people with at least 5 years work experience, have gotten some more training, master's, PhD level, that can actually do innovation and come up with solutions that are not just problem solution fit, but the product market fit as well. Then we also look at it from the government, and we ask ourselves, if the health technologies for Africa are not going to come from without and they have to come from within, what needs to happen? What kind of agenda should the government be setting up? And the agenda for government, on the government side, needs to be creating a knowledge-driven economy, so that for me as an investor and for academia, when they're doing the heavy lifting, because R&D is not cheap, early stage investing is not cheap. We are going to need to have a government that needs to speak to our needs in terms of either tax incentives, in terms of being able to provide more funding than just research funding. I think Kennedy was just talking about IP. One of the challenges I meet is, again, innovators patenting way too early. And what do I mean? You go ahead and you register for a patent, and you've got no clue how you're going to raise the money to do the PCT side of it. And that means your entire IP, you're awarded a patent or a utility model or whatever it is for just a single country. And at that point, you have now become uninvestable to me as an investor, because I'm thinking, my goodness, I've got absolutely no protection in all the other markets. And it's going to cost us this much to be able to develop the idea to product launch, and then start thinking marketing cost and all these other costs. So, and typically when I look at, from my experience in Buildgroup, I can tell you, for most startups, you probably need about $300,000 to get them to market ready and product launch, and to be able to show enough market traction for investors to come on board and now allow you to start scaling. So it's quite expensive. We can't do that for our small, markets, not unless you're in Nigeria or Ethiopia. The rest of us in Africa, really, our populations are not that big. So there's a lot of policy thinking that needs to be done. There's a lot of understanding the underlying issues and really owning this space, because to be very honest, we do have a monopoly just because of the fact that our market system doesn't function. So the first question I always ask people is, do we even need a patent to be able to develop technologies and go across Africa? But then the other issue is that if you don't patent, then investors typically are shy to come on board. And then the other thing is that you're not going to be able to scale across fast enough. People will come in with their Me Toos. So yes, we can't run away from patenting, but we also need to have our entire ecosystem being able to work in a much more harmonious way. We need government to step up, really set the agenda properly, create the enabling environment for, and by this I mean health sector specific innovation systems that really can be able to allow professors to set up startups, to allow PhD, postdoc students to feel it's not just academia or research careers that I can follow, but I can actually take these research outputs and create a startup, and investors knowing that there's a government that is thinking about industrialization, not from the perspective of EPZs, or come and set up your manufacturing and we give you all the tax waivers and you get free labor or close to free labor, but really thinking, how do we create that virtuous cycle? How do we take the health sector, start creating wealth, start creating local solutions, and be able to scale them, not just to Africa, but to the rest of the world. I'm going to stop there and looking forward to more conversation and questions.
Robert, thank you so much. If only all investors had that sort of approach or that view of what they're investing in, the bigger picture, I think we would, it would just make for a much happier and more healthier environment for, innovation and across the continent, across the world, to be honest. You touched on so many things there, and one thing that you said that is very much something that came up in our first webinar was about the value of the partnerships and the different people that need to be involved in order to create, especially in this case, we've talked about academia and we've got a lot of academics here today, but what that knowledge and experience can bring to the innovation process. In the first webinar, we talked about partnerships between regulators, policymakers, the actual innovators, and also others supporting, like academics. And I think this is very much of a theme that's running through these conversations on health tech that we've been hosting, and it's something that we as a network are very keen to continue. I'm also so pleased that there's so much connection between all of you right now in this group, and as with the first group, that I think we'll almost already have the first sort of collaborative network already that can actually start to kind of push and lobby at different levels for something that actually will work and will work on a longer term sustainable basis. I just needed to sort of note that. You also said something about insurance, and I think Maxine said something about insurance. And it's something that I will want to ask each of you to kind of say something about, because the out-of-pocket issue is huge. I didn't realize quite when you put it in those figures. That's quite startling. But what are the solutions? The US, I think it was, I don't know if it was you who said, how much is actually spent on, but it's public, it's private money. In many European countries, it's publicly funded, obviously through taxpayers, but in Africa, it's a different issue, so it'd be worth touching on. I have a quick hand up from Kenneth, which I'll take very quickly before I move on to Willetta to talk a bit more on that policy environment issue.
Yeah, sure. I'll just be quick. As Robert was speaking, I was just thinking about so many things, especially the last thing you mentioned about assurance. And this, perhaps I was hoping we could either be able to touch on this, or maybe it needs another webinar. But from what he mentioned, especially regarding the cost of setting up that, and the example he gave of the farmer having to wait 3 months to be able to go to the hospital, something that we don't discuss, and something that I don't know why, is traditional knowledge. And perhaps it's because of the setting where we have our healthcare system based on the pharmaceutical industry. Now, what that happens for countries like Uganda, or countries that have traditional local knowledge, is that then excludes them from the system, because it's such a travesty that someone needs that I would need a PhD in order for me to identify a herb which grows in my compound. And yet, these are things, this knowledge has been passed down from a generation to a generation. The question that I want to pose is, if we actually try to invest or push for traditional knowledge, in the sense that, because we've seen it from the Madagascar incident, where Madagascar came up with a cure for COVID and the Western world rubbished it. And then months later is when now they're seeing and using the same cure, and that's what they're actually rolling out now. But of course, we understand the considerations behind it, in the sense that the pharmaceutical system is different from the traditional system. But should we have such disparities, especially in this day and age where now we know for a fact that most of these medicines work? Wouldn't this be cheaper if we actually pushed for traditional medicines and herbal medicines to be able to cure us in Africa, in Uganda, as compared to pushing for going to hospitals and the like, where the money is still being channeled to companies that are not maybe ordinarily resident within the jurisdiction? This is something I wanted to just pose to all of us.
Thanks, Kenneth. That's throwing an interesting spanner in that works. And hopefully we'll cover it at some point as well in this discussion. We don't have a huge amount of time left, and I want to leave some time for questions. But I just wanted to ask Willetta from what you've heard so far, and really the emphasis on the policy issues, because we've talked about the sector in itself without kind of, looking at what the policy environment is or isn't doing. I know you're probably very familiar, obviously, with the Ethiopian side of things, and you mentioned earlier that there wasn't even a law on health, let alone on health tech or anything. So what are your thoughts on, if you look at it from a startup perspective, what needs to happen in that environment, and what are your and what's missing from it currently?
Thank you. Actually, this has been very enlightening. When you were speaking in the US, we have cut and paste legal documents, websites where we can go and take it and then use it. Another country, Estonia, for example, is everything. So why don't you all create something for us, for Africa? That will really, really help us all, because there are different kinds of, so all my life, I've been in NGO, I have directed multi-million-dollar projects, I've been a teacher. Recently, I became a startup. I said, why not? The reason I started it is because donor-based programs, they have a beginning and an end. And when they go, the ministries, the hospitals, bye-bye. Some system is put there, I put a system through donor funding. When it's finished, it's very difficult to continue it. So I said to myself, we have so much talent, why don't we start our own thing? From the little, I don't know about South Africa, maybe Kenya a little, it's very difficult for startups in terms of financing. Even, for example, I'm experienced, I've been in this field 20-something years, I know what is needed. We created an electronic medical record where we can track the patient from when they get to the guard till they see everything in a hospital and come out. I don't think there is something like that in Africa at the moment. How did we create it? Using all our years of African experience. We need to make it simple. We cannot have it take 10 years to develop a pharmacy or a laboratory or outpatient module. It has to be very fast. So all this experience, and then another bar that we need to get to jump is we need to make it to meet the international law policy. We need to make sure it's not an African product. It has to be at that level. So one thing listening to you all is humbling, to be honest. And the policy aspect, so in Africa, in some countries, the public sector is more, like in Ethiopia. In some countries, the private sector is growing more, in Kenya and other places, South Africa maybe. So it's very difficult, the policy, I don't believe, let alone for health startup, for other startups, IT startups, have gotten to that level where it can nurture the best startups to support the country or different countries in Africa. So the more and more we are doing it, we are baptism by fire, I call it, So we are doing it, but I've always thought about it. It has to be a Pan-African collaboration. If Andrew is doing pharmacy there, I'm doing EMR here, somebody's doing in Uganda or in Angola something, why can't we collaborate? Why can't we collaborate so that we can bring the standards so high and we can influence policies? Policies, I'm not talking about what Kenneth says. I totally agree with you. If there is anything we can do from our side, we have the School of Law. I work with different lawyers in Ethiopia. I have a brother who's a patent lawyer, but in the US, I will be very happy to encourage you to bring it more than Uganda. I think to benefit all of us. Robert, people like you don't exist. You are very, very difficult to find people like you. So you all, I see you because I think you understand our problem from all sides. So how can policies are not there, or if they are for startups, it's not very conducive. For example, because of this problem, I started my career from training more than 3,000, 4,000 young people, and all of them have a job in Ethiopia in health IT at the moment. 7 years it took us. But one of the problem we wanted to crack was to take IT, the others were high school students, all level. And we trained them 3 years and then they are all over now. One of my I did work with Jimma University, created masters in, the first African masters in monitoring and evaluation, all that fine. But one of the last thing I did, I hope, that would benefit was to take the ITs, train them, give them world-class certification in Microsoft. In my case, we work with Microsoft, but it can be Cisco and whatever, and then help them to start a startup, a small startup. That's the only way we can make sustainability. And then all these issues that Kenneth and Robert are talking about will come up. Policy will come up. So I used to work at this level, but I'm now a fighter from the bottom-up level. Because I think change in policy can happen. People like us, if we keep on loud, speaking, doing, then policies will change. Sometimes it's very difficult to crack it at, we have a very big, very well-funded, very good ministry now, Ministry of Innovation in Ethiopia, that does similar what Kenneth is doing with the Ugandan. So they are there. They have now their, 10-year strategy for all not only digital health. I think that's a good way to go. But there are so many parallel systems. How do they do it? How do they regulate it? When somebody comes and says to you, I give you money, but you have to do it this way, can you say no? I don't think so. So all these issues, the only way I believe, since I've seen it this way, we can crack is by people like you. If we can all bring it up little by little, can be started in West Africa, in East Africa, South Africa, whatever. And then we bring it up, we bring solution, then we bring strengths. I don't think we can survive alone as a simple startup alone. I have seen it, and we have 100 million population, even with that. I think if we collaborate more, if we bring some of our ideas together, and then we add it, you know, and then I think then we can build Africa-wide, very secure. And if people like Robert are out there, many of you, I hope, then you can help strengthen all of us. People like Andrew, us, you know, we can help us. And then we have people like Roy. I know the Resilient Network, but I didn't know you went this far, because I know the Jumma Network. I don't think the Jumma Network is doing us what you are saying, bigger like you are doing, but it's donor funded. I would like it to be sustainable by the government, so that something unique like this should be in every African country. And the government should encourage these young people to innovate. My dream, if you ask me, one day we should have an Africa-wide big hub where we can have all these people from all countries, all these young people, all older people like me, can come and innovate and solve all our, most of our problems. We can, but you know, little steps.
Well, I tell you what, we already have the makings of that platform and that panel right now, right here today, and combined with the one we had before. This is very much, as some of the delegates attending this webinar who spoke last time will definitely be nodding their heads, because this is something that we all felt, that they all felt extremely strongly about. And that's what the Alt Network, you know, our objective has always been, to create these Pan-African conversations and platforms. And so this one is top of our list, definitely. You said something just now, Letta, the funding and, you know, the donor funding. Again, in our previous session, one of the issues that came up was the role of donor funding and donor priorities influencing what happens in Africa. And one of the speakers from Mozambique last time, she was talking about how the Mozambican government would have a 5-year public health strategy, but very quickly, because of the need for funding, donor funds that would come in, which had their own objectives or what they believed to be the priority, would kind of prioritize, would take a priority over the locally defined needs. This is a perennial issue, I think, across all sectors in Africa, because the reliance on donor funding and how you move from a donor-funded project or activities to national funding, which is what you've just been talking about now, Letta. Roy, I wonder if you have any observations on that particular point, because of the Resilience African Network, I believe, has donor funding.
Yes, we have some, just a quick case study to share. When we started, we had a $25 million grant from USAID. And after 5 years, it ran out, and we were notified that it was not being extended. So that is exactly what you are speaking. I mean, the challenge that you are bringing out. And the second thing is that the donor funding tends to focus on certain areas of innovation. Like, for instance, the initial grant was supposed to focus on innovations that build resilience. Fortunately, resilience was a broad theme that could include health issues and other livelihoods issues. But if it were another funding frame, then it would bias the types of research areas that could come out. But there are ways in which towards the end of our award, we started discussing sustainability, and I'm happy that it came out. We've not yet replicated it across all our labs, but in Uganda, we made the case to the government of Uganda, and the government gave $8.1 million, and they've given a guarantee for 3 years. We finished the first year of that funding, and we are now starting the second year, in which they have appropriated another $8.1 million to the university to support innovations. And the university has subcontracted us to manage the process. So for me, I think, and the Treasury had so many questions. They say the government has different interests from the usual innovation cycle. They want results in 1 year. They said, we have 1 financial year. If you fund your innovators, we want them to have something that is scalable in 1 year. You know, so they have all these, and as you're trying to sell your pitch to government, you have to explain to them and you have to show them that you respond to some of their needs, and then they will appropriate money for you. But it required a very big advocacy effort to get the Treasury to just accept that these high-risk ventures can result into some innovations that can contribute to national development. And also the way you package when you are pitching, tell government that you are going to address national priorities within the National Development Plan. So the Treasury said, we are not interested in resilience or other things. We want you to root your solutions in the National Development Plan. And then we said, yes, we are going to identify the key areas in the National Development Plan and repackage them into interventions. And usually there's not a very big rift. So we managed actually to secure an appropriation of $8.1 million equivalent. But the other thing that you can do is facilitating these innovators to look for extra support. Some of the innovators don't know how to write proposals. You help them, you handhold them. And that's how some of our innovators ended up in Robert Karanja's ecosystem. Then he took them up to another stage because for us, we were focusing on early stage ideas. And then Robert took them on because he was more into the late stage ideas. So the issue of handholding the innovators, there are other innovation small grants that we are closely linked with UC Berkeley, where they give small grants of $5,000, but the innovators here don't know how to write a pitch that sells. Then you help them to get that additional funding. So that's another one. And then the other one that we need to look at eventually is commercialization. Like Robert said, and I think someone else, that the academicians are not looking at commercializing their products, and yet some of them could be sellable. We have produced a ventilator, but we don't yet have a clear clue on how it is going to enter into the market chain of East Africa and even Horn of Africa, because it has the potential to go there, but the hand-holding that is needed to introduce it to the market, to all that, even overcoming regulatory issues, how do you certify the ventilator to be used across the entire COMESA region, for instance, or you know, those are the issues, and we'll later talk briefly about them. So who moves the ventilator out of the university to the region? So, those are other things to think about. There's only one thing I want to talk about which is not related to this, and that is regulation. The regulatory environment for innovation should be slightly different from the regulatory environment for everything, because innovations are in a stage where they are being tested. We have an innovator who started an e-wallet for people to save for health. And the next day, there was a big half-page advert in the newspapers from the central bank that whoever deals with this person is doing so at their own risk. They don't understand the innovation process. They don't understand that, and they said, for you to do anything to do with money, you must deal with a commercial bank. None of the commercial banks is interested in these high-risk ventures. They don't want to work with them. And you have to deal with the mobile telephone company. So, and then the innovation died. There's need for interim licensing that can enable innovations to work within preset limits until they reach a stage that they can get the regular certifications. We've also seen it with an innovator who has a radio that moves from one village to another, and yet the Communications Commission issues a license for only one district. And yet this radio is supposed to move, you use it in one village, lend it to another village, lend it to another. In that particular case, we sat with the Communications Commission and participated in writing the regulation, the type of license for that kind of thing. So that is part of what should happen in facilitating some of these innovators. Otherwise, their ideas can die very quickly because of the regulatory environment. I'll stop there.
Thank you, Roy. That's actually a very good point, because we spoke about it quite a bit at our previous webinar on the regulatory side of things and the needs for that. And that's one of the aspirations we have for the platform that we hope to create after these 2 sessions, and really how to push for those sandboxes, which you see more of in fintech, for example. You have some fintech sandboxes. And in fact, we talked about a health tech sandbox the last time. It sounds to me like, I don't know, it's hard to see how you can have one central African one. But in fact, what Willetta said earlier about the cut and paste culture, and there's no reason why we can't do very similar things if we can have model policies or model regulations. But you're right, there is a difference between regulating an already finished product in the health sector, for example, but also regulating for that innovation.
One little thing I also forgot regarding funding. I think our private sector needs a mechanism where you can tell investors that this innovation will generate so much profit, therefore invest in it. Here in Africa, we are lacking like well-structured venture capital that looks, and part of the reason is that even the venture investors do not know which is likely to be a good investment. And like Robert said, many of the innovators with these ideas are very inexperienced. They are grappling with quite basic things, not even going into maybe starting a company. They don't know anything about equity. How do I sell shares within this? And what are my potentials, funding potentials? How much, when will I pay you back? You know, those things. So who tells the investors that this business is good, it will generate $1 million after 1 year, therefore put your money? We don't have that, and because of that, we don't have structured venture capital from local investors. There are some, but driven by impact investors from outside, but the local billionaires putting money into viable projects is not yet well structured, because they don't know exactly what universities are doing and how it will make them money. We tend to make things thinking that they are public goods, and yet the investors are interested in the money and the profit margins.
Thanks. Yeah, completely spot on, Roy. I actually want to ask Andrew and Maxine very quickly, in terms of this issue of educating and informing the regulators or indeed the investors, actually, from your 2 perspectives. How has it worked for you, Andrew, with Redbird? And how have you had to engage with regulators, and what have you done, and what kind of tips do you have for others who might be trying to do something similar?
Well, yeah, thanks for the time. I think I'll start with their investors. I think, and Roy, you nailed it. Most of you do realize that the African concept of business is totally different from the venture capital style of business, right? You put in money today, and the business is looking at how much do I make back on that money. It's not looking at how much shares, how much equity do I have. Like, we see money, not equity money. Like, if you tell any investor, give me $100,000, and in 5 years, it could be worth $1 million. They want you to go take $100,000, buy a box of chocolate that you could sell for 120, where he can see this is my money, right? He's not interested in the paper thing. And it's been, for us, I think we saw that quite very early on. So our focus in fundraising had been totally external to the continent. We incorporated right in the US, raised funds out of the Silicon Valley, and then did a startup, and then now looking to now raise funds from investors that have moved from the Silicon Valley and are now looking in Africa. Part of the challenge also is if you look at the Silicon Valley, there's examples. Like if you put in your money, this is how you get it back. Or people put in your money in Cuba, this is how they made it back. If you look on Africa, we've had very little exits. So it's getting there. We are behind the curve, and I think I wouldn't say we are lost. I think we are on that path. In terms of regulation, yes, it's a tricky one. We as a startup, I think what we initially did was we tried as much as possible to. It's difficult as Redbird, a startup with very little capital 2 years ago to try to change any regulation. So what we actually did was we sat back, look at what was already existing, and saw what was legally possible for us to do. I think there were some that were straightforward, like data protection. Fortunately, Ghana had a law on data protection and like what you needed to do to register. So we did that. In terms of managing the logistics of a startup in the healthcare space, we use existing partners. So we use channel partners who are already certified to do that. We know as we start growing and we have a patient app, we've tried very much on the app for it just to be a record-keeping app. Because once you start giving information, there's not much regulation, but you need to do that. So it's more of looking at where you can fit in. And then as you grow along the line and you're demonstrating value, it becomes now easier to go back to the regulator. Like we feel much more confident now to go back to the regulator and say, okay, you know what, we already have this number of people using our system. These people could benefit from feedback, information. There's not much regulation along that line. How can we get this to work so that at every given point in time, we are at the table? You look at even regulations on investment, for example, in Ghana, if you want to do the kind of work that we did, if we tried supplying it right off the minimum capital requirement was $1 million. And no one was going to find $1 million for an idea. So you look at those parts, and there's been conversations on trying to improve those as well. But my advice to anyone who's like on a startup level is take the time, speak. You don't know it all. Get partners and speak to people who understand and let them advise you on ways in which you can fit in. So sometimes also we see people trying to trying to fight regulators because they are innovators, but that is a dead end. Like not even the big corporations can fight the regulators. So you need to be starting those conversations, building the relationships within those regulatory bodies and letting them know your vision and like what you're trying to achieve. So that at any given point in time, I think what I've seen is people respond better when they feel like this is for the common good, right? They feel like, yeah, this is something that we want to support. This is something that we have to support. You're not exactly sure how to support it. But then they don't shut you down, right? So if you want to do something in finance, yes, it's innovation and all that. Have someone in your corner in the central bank. There may not be regulation, but speak to them, like have a conversation, let you know, this is a person, have some introductions, and people are able to, on the quiet, encourage you, guide you, no, this is totally a no-go area, right? This is what maybe you can do. And then you start those conversations along the line. I mean, regulators, unfortunately for us in Africa, you know, there's power play. People see you as a threat, they will take you out easily. So you need to navigate. It's a bit of like an art. Like you need to know how to navigate that. Not saying that we've been able to do it perfectly, but I think we've been able to form the associations, have contacts with the pharmacy association, have contact with some clinicians, had contact with different people around the chain, so that at every given point, at least we know we are not caught up, like we know what may be coming. And there are others that are basically like your tax requirements. Make sure all the things that are within your control are totally set. Anything that comes up for us is like, okay, this is new territory. Let's sit down. Let's solve it.
Lovely. Thanks, Andrew. Just to be fair to the African regulators, I think all regulators are generally sort of behind the innovation. They rarely lead it, and they always need to be encouraged and pushed a little bit, and some possibly more than others. I just want to ask Maxine, and I realize that we're nearly out of time actually, and I've asked attendees to put up any questions or comments they have whilst we have this final bits. I want to ask Maxine the same question around community engagement, educating and informing regulators. What tips and advice would you have?
Yeah, so absolutely to echo what Andrew said, in the absence of regulators having the appropriate rules, the depressingly important role of personal connections is absolutely the same like around Europe, despite being a very regulation-heavy environment. So having a regulator friend is a very helpful thing for any innovator. So it was making me think, we're less making the call to action around a Pan-African approach, and in some respects we have an equivalent in Europe. We've got the EU. Obviously, the UK left the EU about a year ago, but we were meant to have a new medical device regulation come in May this year that was at least an initial attempt at dealing with some of the bigger issues that the new health technologies, such as ones using machine learning, have. Now, that was delayed because of COVID, but that's taken a huge number of years to get consensus across so many countries on what the regulation should be. And so in the UK, there's been a really interesting approach about what the policymakers have done in the interim to kind of fill that regulatory gap. And I think this can be thought about from, and applied in lots of different circumstances, is that you can't be too prescriptive if you're a policymaker because you're not the regulator. And so the rule of a new entity that was set up in the UK was a thing called NHSX. And the approach they took is, we will define the rules of the marketplace, but the market will decide. So that could be things like what standards you want in place, or what is a fair commercial deal between a hospital and a startup, or what is an appropriate tendering process for a new type of innovation that's not going to lock you in for 10 years for an EMR that doesn't work. And so there was a whole set of rules that they wanted to agree, and then actually in the ways in which those things are carried out is up to local groups. And I think that can be applied at a national level across regions or a pan-national level across countries, because that allows for the local flexibility, but it has a kind of hard safety net for where the government in question or the decision maker or the policymakers in question would be uncomfortable going any further on. And I think that has been the most useful way of approaching it, because as a result, policymakers have taken all the examples of what's happened locally and seen what has worked and what hasn't, and then the stuff that's worked really well has bubbled up to the policy level. Now, as long as the rules of the marketplace are co-designed with the innovators, like if you don't do that at the beginning well, then you're stumped from the beginning. But that process of constantly consulting the innovator community and really co-developing those rules of the marketplace was something that was fairly, I think, novel that NHSX in the UK did. So that would be kind of my main takeaway, is being a more principle-based approach in the absence of proper regulation. But in order to do that, you require people to engage in innovating in a fair and ethical manner. And obviously not everyone plays by that game. So there are plenty of examples, and I'm sure you would all have it in your respective countries, but there are plenty of examples where even if one innovator takes advantage of a loophole, it ruins that community idea of, there aren't any rules, but just because there's a gap, it doesn't mean we should exploit it. And I think that's something that certainly from a One Health Tech perspective, and lots of other people in the community say, is that we're all swearing an oath together to make sure that we are approaching this gap of regulation in an ethical and appropriate way.
That's great. Thanks, Maxine. That's really a very useful way of thinking of it, actually, a principles-based approach and kind of helping the regulator to come up with what their priorities are, and therefore how the health tech innovation can actually evolve within those priorities, and to keep them informed and educated on the issues. Maxine, I know that you need to go in a minute, so we will let you go when you're ready to go. And I know Andrew's got a meeting coming up and we're slightly running over time, but we don't seem to have many questions. I think we've seriously addressed tons of issues in this conversation. So in the little time that we have left, I do want to go back to the insurance point. I want to ask Robert what your thoughts are, just as a final thought. So that kind of from everybody, just keep that insurance and the access issue in your final comments, please. I just want to start with Robert. You're muted.
Thank you. Yeah, so I think for me, the insurance space is something we can't ignore. And I think I'm glad within the SDG, there's this universal health coverage. That's really getting governments to think of how do you set up a public health insurance system. But even when they do so, what I've realized is that, like Kenya, we've had one for decades. And till today, I don't think our public health, National Health Insurance Fund has a coverage of more than 20% of our population. Private sector, we're talking of probably by the end of last year, we are getting to about 4% market penetration by private sector in terms of health insurance. Now, putting the COVID and the disruption it has done in the economy, I'm sure it's going to go from 4% to probably 3% or something like that. But that story is the same pretty much across Africa. And that's what's painful to me. And I think there's lots of scope for innovation that can help us to come up with insurance that's built for us, not insurance that's built for white collar jobs. You know, like I was saying, if I'm a farmer and my cash flow is based on that season, I need an insurance that I can pay premiums based on that season. If I'm working in the informal sector, maybe as a hawker or something, I need an insurance that can allow me to pay premiums, you know, based on the little I'm earning per day, you know, and things like that. And being able to think through premium financing, being able to think through micro insurance and ways that can actually allow, you know, B2B, you know, or B2B2C. Because again, just like we have, and I love the way the agriculture value chains tend to work, because you always find aggregators playing a key role. And the health insurance can really piggyback on a lot of those kind of aggregator mechanisms, the cooperative movements and all of that. So but we do need to do something, because if we don't do it, our health system cannot be able to adopt innovation. And so we continue to be dependent on donor funding, and we continue to import health technologies. So breaking that cycle is really critical. There's lots of work to be done. And I'm glad that we've already talked about that issue of the central bank in Uganda, you know, taking forever. And this is really our experience. One of our startups has taken more than 2 years just to get the central bank authorization for them to start operating. Now, any other investor, for us, we come in with the mentality that we're an impact investor. We're coming in with a lot of patient capital. But really, it shouldn't be patient capital of 2 years pre-revenue, because the regulator is not, you know, conducive. And even getting our governments to understand, because some of it is just boils down to the government mentality. In most cases, most government employees, their number one instinct is preserve your job. It's not take a risk and listen to this startup that has got a brand nobody has ever heard of, no cred, you know. How do you change that mentality? You know, even the culture needs to change to allow innovation to actually take place. And I think it's going to be the one area UHC must really take off. We must achieve that SDG for the other boats to rise. I'll stop there, but then the other thing I also just want to highlight is the need for intermediary organizations. And thanks, Willetta, we do need more build crews. We do need more incubators, accelerators that are speaking to the health sector, that are speaking to academia, and helping people to actually learn how to build businesses like Andrew is, like Willetta is, that can work with venture capital to scale and can create that value proposition. And the beautiful part of it is this. People like Willetta and Andrew are creating jobs in the formal sector. Even if they're startups, what our governments are not understanding is, especially in the COVID-19 like economic stimulus that I'm seeing them putting out, is that they're trying so much to cater to the common citizen. But the common citizen tends to work in the informal sector. And they're taking the tax that's coming from the formal sector and pumping it into the informal sector, creating a bigger and a bigger gap, or financial budgetary gap. And that needs financing from loans. So again, we become poorer. How can we also have a financial stimulus that also allows them to recognize small and growing businesses? There's no reason, there's nothing that prevents our governments from also setting up government VC funds that can invest in this kind of startups, so that it's not always having to set up a Delaware Corp or to set up, you know, our companies in countries where investors exist. The way we started at independence was actually the government moved, had to take the role of private sector until private sector could mature. And I think our governments also need to do the same in this case.
Thank you, Robert. I agree wholeheartedly with you on that. And indeed, even the US government to this day, many Western governments do invest. They just don't say that they're doing it because, it goes against the whole idea of public-private. Yeah, they do. But I'm just gonna, because we're running out of time, I'm just gonna ask Kenneth for your last words, please. Kenneth, we can't hear you. Maybe I'll ask Roy while Kenneth is fixing his tech.
Yeah. My last word is just the fact. I think it's a fact that digital health is a very ripe area for growth. I mean, there's so many. Healthcare is made of processes, and where processes are, health technology can facilitate and smoothen out the processes. That's my last take. On the issue of insurance, I just wanted to note that we need to understand the user. We can only develop a solution that understands the user. We have small savers. We have a mother who goes through 9 months and they've not saved even a single shilling for their emergency delivery. How do you get them to save in little increments? And we have the opportunities for mobile money and these platforms that many people in our region are now interacting with. How do we get them to save the little in a basket? And maybe we may need to think about it first, not as insurance, but a health savings account. And then when people are up to the saving, then we can see how we can pull risk. So that's my last take on that.
Fantastic. Thank you very much, Roy. Kenneth, are you able?
I think so. I hope you can hear me now.
Yes, you can.
Okay, so I'll just quickly conclude. I was saying that I just really just wanted to sum up exactly what Robert mentioned, in the sense that looking at the health sector, we need to look at the whole entire ecosystem. In the sense that looking at if you're looking at it from the insurance perspective, it wouldn't make sense, for example, to push for insurance if the actual people cannot afford the insurance. So why not first look at, if you're looking at our markets in particular, why don't we come up with solutions that are curated or that affect our particular economies, in the sense that from the things we're talking about before, traditional medicines and the like. If you try and promote things like healthy living, if you try and promote mindfulness, we have, Uganda, Kenya, Tanzania, these are all food baskets. So if you promote nutrition, on top of, promotion, if you promote things like mindfulness, and if someone falls sick, you say, okay, first, let's see whether we have the medicines locally before going to a hospital. I think if we do that first, one, you have a healthier population, but number two, the people that then need to go to hospital, you have the hospitals decongested, and then you find also the insurance companies themselves that are charging the insurance. It's very easy for them to create packages that will be that the wananchi can be able to afford. So I think looking at insurance, we need to look at the entire ecosystem and be able to come up with solutions or products that, one, help the patients, being the citizens, and then also help the innovators and the people that are trying to make the businesses, but also have solutions that do not also put unnecessary burdens on governments or on economies when there are always other solutions that we could have brought forward before actually talking about money. So that's what I would say.
Thank you very much, Kenneth. Prevention is better than cure. Willetta.
Thank you. I think the last, what I can say last is we can work to foster collaborations. I'm, academic to academy. I'm already thinking the email I'm sending to Roy. So there are things that we can do. Andrew, I would love to show you some of the things that we do. so that we can collaborate. So I think if the network can create, even the last 2 weeks, guys, very interesting things, if we can collaborate. Kenneth, I think you have a lot of thing on your shoulder. You have to help us all in the legal side. Not only even COMESA, I mean, even, even if it's not yet African-wide, I think the African Union made the declaration that now people can move with no passport within Africa. I think they did in the last meeting. So that is going to create an amazing trade and movement of people and things like that. So I think and ideas. So if we can do that, and Robert, well, you have to tell us how we can create something like you in all our countries. How to do that so that we can encourage. I'm sure there are people, it's just that there is no network to talk. Some of the issues that you raised is fascinating, and I'm more hopeful now when I see you all. I'm more hopeful. There are many things, people who are thinking the same way. It's just that we are in different countries, in our countries. So it seems that we are all thinking the right direction. So if we can, get something out of it. This conversation has been very useful, and I will invite you all to some webinar to talk to our students. I hope you won't say no. Already I'm inviting you all, so I'll arrange something so that the students can hear we are all thinking the same way. Different part of Africa, but we are trying to solve similar issues, but in a different way. So Nakunda, I cannot say much except to say thank you very much for this opportunity. Maxime, I think what she has is a very interesting thing. Please inform her. We'll be happy to do something with the last week guys, the drone guys, and some of the guys I heard last week or 2 weeks ago. Very interesting things. So thank you.
Thank you very much. Thank you so much, Lett. I really appreciate that. So finally, last but not least, Andrew, your final comments.
Yeah, thanks. I think we've said it all, just about jumping off. I really feel that the collaboration is what we need to do. I mean, Africa, unfortunately for us, has been fragmented a lot. So the market seems very fragmented. But then with collaboration, you'd be able to do much more. I mean, the volume of work that is needed in the healthcare space, to me, it's huge. So instead of every person trying to do everything in the place that they are, I think it would be good to leverage things that someone's already done, bringing new technologies through the system. Like I was excited when I was hearing, oh, we have ventilators and all this, right? If we get tools that could be used rapidly, then we have the network that could possibly bring those on board. I mean, we have the legal team. I mean, to be honest, we outsource most of the legals that we have outside the continent, because there's very little, not much, even though it's growing, not much expertise, for example, on like IPs, VC term sheets, and that you speak to colleague lawyers and friend lawyers, and I'm like, oh, we want to set up this, and everyone goes blank, let me go do some research, right? So having people in that kind of space to help and to guide, and those are essential. And just like I said, those are like the soft sides are just as essential as the hard business that you're building. People, most often we think the innovation is what's up. Like there are so many innovations sitting on the university shelves that don't go anywhere because I say the energy or sort of like the skill needed to bring up innovation, unfortunately, is a bit different from the skill needed to grow the innovation. Like the growth mentality is structured, like you can play with things. Innovation is free, you can play with things. So getting all those balances and getting them in place, it's something that I think we all need to foster the collaboration and do. Lastly, for me, I think if you think of what a government can do, there are places that, especially with innovations that are already existing, there are places that are just, even on the main places, are non-profitable, but then are very essential. So those are the places where you have government put in, like you're speaking about technology, connectivity in rural areas, right? If I try to build up a solution that works offline in rural areas, probably struggling to even meet distribution between just 2 points. I can just get all that from one part. But you have government that has structures that are already inbuilt. They have distribution network, they have existing things. So government's coming up with sort of like looking at innovations and looking at how they can incorporate those into the existing channels with very minimal cost. It's something that I think we should look at. And thank you very much, Akunda, for putting this together. I think you've done a great job. Yeah, we are routine. And you started a network, like Dr. Ulema said. Keep it up. Like, I'm happy to share information and jump on a call, speak to students, do anything. And hopefully we'll be happy to hear a bit more of like your IP, medical privacy from you, like from the legal perspective, what you've seen on the African continent, and like innovation ecosystems that you're building. And if anyone needs to do something in country, in Ghana, like hit me up. I think it's a good start. Happy to meet you guys all. I'm just jumping on another call with an investor. So thank you very much. Audin, you for the final closing.
Well, thank you, Andrew. Just very quickly, I want to thank all of you for your time, for your insights, for your inputs. It's just been fantastic. And it's been, for us at the network, this has been a really wonderful experience. And the colleagues who spoke at the first session and this session, I think we've more or less covered the whole continent, to be honest. And so many of the things are the same. So our intention is to continue this conversation and for the Alt Network to bring this conversation together as a sort of at a continental level, and hopefully by being on one platform, we have greater influence on the regulatory side, on the government side, the contacts that everybody has, and just even being able to, as you said, Willetta, to invite different people to come and speak to your students. Similarly with Roy, I think those kind of connections are what makes a stronger factor. So we will be in touch with you shortly after this and to introduce you to the other panelists from the previous one. Some of them have been here today watching, and to then plan what our next course of action is. But thank you very much. It's been really inspiring listening to all of you. It's been such a pleasure. And have a good day, the rest of it. And thanks to our attendees as well.
Thank you. Thank you very much.
Bye.
Bye-bye.